Uh, Thanks, Writer Person Sipla, for giving me the opportunity. Today, we are going to discuss about the topic of heart failure and its diagnosis. So, heart failure is most commonest medical and cardiological diagnosis what we see in a lot of patients. So, how heart failure is classified and how what is the definition and what are the treatment modalities and what are the new available modalities we are going to discuss. So, heart failure is divided into three types of classification depending on the percentage of ejection fraction. That is heart failure with reduced ejection fraction, which is most commonly seen. Heart failure with preserved ejection fraction and heart failure with medium range ejection fraction. So, heart failure with reduced ejection fraction, most commonly the cutoff value is less than 40% of ejection fraction, and preserved ejection fraction generally we keep the cutoff of more than 50%, and mid-range ejection fraction we keep in between 40 to 50%. So most commonly the reason for reduced ejection fraction would be with Indian settings and with the high risk for CAD, coronary artery disease with LV dysfunction is very common reason, followed by valvular disorders, followed by tachycardiomyopathy, and we see a lot of patients with dilated cardiomyopathies. Next come post myocarditis, and patients with lot of patients with CKD can have CKD LV dysfunction and hypertensive heart disease and diabetic heart failure. These are the reasons most commonly the patients present with reduced ejection fraction, and patients with preserved ejection fraction. The most common categories would be with hypertensive heart disease because of stiff LV, diabetic heart disease with the normal ejection fraction, especially with diastolic heart failure, and valvular disorders and hyperdynamic heart failure situations like wet beriberi, severe anemia, and CKD patients with preserved ejection fraction. With fluid overload status, we can classify them as heart failure with preserved ejection fraction. And patient with severe pulmonary artery hypertension can be categorized with who present with right heart failure. Well, a normal left LV ejection fraction, we classify them as preserved ejection fraction category. Most commonly, these patients would be elderly and females, and also obese category, who with lot of comorphs. And mid-range ejection fraction would be patients could be possibly reduced ejection fraction category improved to mid-range, or patient with preserved ejection fraction slowly going into low ejection fraction and creating the falling into mid-range ejection fraction. So how would you diagnose the case? So whenever a patient presents with important symptoms and signs, most common would be uh, class like dyspnea, history of any chest pain previously. The patient with chronic rhythm abnormalities can present with palpitations and systemic features like uh, swelling in the legs, facial edema, and over a period of time they can develop PND followed by orthopnea. So when they come, they present with these kind of symptoms, and you should evaluate the signs of heart failure like presence of systemic features of fetal edema, we raise the JVP. So severe LV dysfunction, you expect pulse to be in pulses alternance, and severe LV dysfunction can have low perfusion pressures, which can have cool extremities, with low pulse pressures. Srinivas, you're there?